I'm Jens Chapman, and it's an honor to be here and a great privilege. And whenever possible, we'll switch. And thank you for filling out the questionnaire. So the mysteries of the cervical thoracic junction, and as you heard, the spine is a story of balance. It's a dynamic balance. What frustrates me to no end is having this degree affinity that we now have and not understand that our skeleton is an amazing, dynamic, flexible, muscularly and ligamentously check-reined structure that should be in alignment. So please don't just reduce the spine to a number of angles and distances. I'd hope to basically identify and reflect with you on the complexity of the CT region, approach concerns, and then reflect on surgical stability. Quick wake-up question. You're being asked a trivia question by Neil Patel. How many vertebrae does a giraffe have? How many cervical vertebrae does he have? Evan?
7.
7. Why? Who wants to do more? Nobody more? It's right. The cervical spine has 7. It's just one of those amazing things. All mammalian creatures have 7 neck vertebrae. Just a little factoid. So good one. You must be in LA. So the cervical thoracic junction will arbitrarily define as C6 through T3. And this is, again, a biomechanical fulcrum spot, a traditional transition zone. And again, this is something that's easily missed by everybody. So preventing missed diagnoses, and then talking about treatment, how to is the key thing. But the first and foremost thing I want to harp on is poor biomechanics. And so this is, again, something that we all kind of accept. And industry has now gone into kind of providing technologies to prevent the hanging neck, the forward neck, the stooping neck. This is a really big deal with aging. And again, I want to really ask all of us to not just rely on x-rays, and increasingly we all get scoliosis x-rays, whether it's with an EOS system or something else. But we should harp on this hanging neck. And this is a really big deal because I think all of us should be far better rehab doctors than the professional rehab doctors, and we can learn a lot from them, but I think we can actually do this better. But the so-called dowager's hump, that's something in the British language, is widespread and a very significant cause for problems in many factions, and that's not just pain in the cervical thoracic junction, but also change in overall balance. So for me, the CT junction has always been one of those really problematic things, and just think about the cervical dysfunction that comes from there. So aging has traditionally been accepted as being a progenitor of poor balance. All of you know this famous study. But I really want to harp on all of us here should make a commitment to being the best rehab doctors out there, because you know what? Guess what? This is not rocket science. And using your hands and eyes and motivational speaking capabilities, such as what Dr. Skaggs has in such abundance, is very doable. And one other thing I want to really point out, and this is a really overlooked thing, is there are different types of neck pain. And we should be able to kind of differentiate this far better than what we're doing right now. And a little question in our group this year, I always ask at the beginning of the years, do you know what sclerotomal pain is, or referred pain? Quick show of hands. Who wants to give a definition of sclerotomal pain? Nobody? But this is one of those many trick questions. There are different types of neck pain, and you need your hands, your ears, your eyes to kind of diagnose this, and not just staring at MRI scans or x-rays. How heavy is your head? Another great trivia question. Again, this is some of the chiropractic literature, but basically the further forward your head projects, the more force there's exerted upon the cervical thoracic junction. And these are your holding muscles, and I think the fewest of you can probably list those in anatomically correct things, but that should not be the case because they're simple to know. And I urge you to dissect the cadavers today and not just cut through that obnoxious red stuff on your way towards a maximally invasive exposure. And yes, industry is harping on this now. They have little reminders, and braces. But guess what? Push-ups, pull-ups, swimming breaststroke style, phenomenal ways to activate those muscles. Enough of that. You want to get to the nitty-gritty. So the C-spine lateral that we all rely on is notoriously bad. This is actually a case from Harborview, which was missed, believe it or not, for 4 days. The patient had a complete cervical thoracic dissociation, and an AP showed that finally when the patient had mysterious problems, was too sick to get proper neuroimaging. But the CT junction and lateral x-rays, which we historically gotten, is not very good for this. It does not show the CT junction, and again, we all know this, and I'm just going to flash through this, but there are many challenges that we have in terms of plain radiographs to actually differentiate this region. And this, as we all know, should be an anachronism because CT scans will show us that to a much better degree, and we all should really be able to rely on that far better now. and understand the dynamic potential of injuries. This is not a compression fracture. This is obviously a far more complicated injury. The other thing I want to hone in on you is expand your view beyond the spine. You should automatically learn to look for the manubrium. And sadly, many x-ray texts don't give you the manubrium sufficiently, but learn to look at the manubrium to spine entry angle. With that, I mean, and I hope the visualizing thing works, you want to look for what does a perpendicular view look like from the manubrium to the spine. That is your best possible. You can stretch it a little bit, but that's your conventional access point to the lower cervical spine. So understanding where your manubrium is relative to the spine is very important, and something that on some MRIs you can see, but certainly on CTs you can usually see it. So you don't want to miss injuries, you don't want to miss pathology in this area, and again, MRI scans are probably the best way to look for pathology. You need a CT scan to differentiate it frequently. But this is a really obvious thing, but it is unbelievable how to the present date we miss cervical thoracic injuries. And we just had a patient in clinic the other day that is relevant. Now, I just dissed ISSG, and I don't mean that really, but I mean it, but I don't mean it. But there's an angle I want you to, you see my conflict, but there's an angle I really want all of us to kind of learn to measure far more regularly than what we do. And Chris Ames deserves great credit in this, and that's the T1 slope angle. This is a very helpful angle to understand on upright x-rays. And again, there may be patients where you can't determine it, but it's really, really important in terms of it gives a whole trajectory of where your neck sits and what the rest of the spine below that is trying to do with it. So you want to look for these forward projected heads. And by the way, just look at this manubrium entry angle to the spine here. Every patient is different, but especially these short bull neck patients have a very problematic manubrium vertebral access point. So this is not a trivial point. Realize also, and this is a alignment thing that is totally overlooked, and my late fellow Charlie Kuntz at the Mayfield Clinic had a great cadaver study on this, and that is the neural axis balance. We need to have a CSF flow around our cord, and if the cord anteriorly abuts like this, even if there's posterior CSF, that cord is going to be compromised. That anterior and anterolateral cord structure is not going to function properly. So having a neural balance where the cord ideally floats in the middle of CSF is something that is functionally relevant for us. After treatment, you didn't hear me wax and wane about this, but this is obviously a critical problem. And we do have to realize that there's not a single external orthotic device that actually immobilizes the cervical thoracic junction. And if you somehow, for whatever reason, seek to immobilize it, certainly you need something that has a cervical thoracic orthotic component to it. A standard collar will not do it. A halo will not do it. You need something that has a tight torso fit, and if a patient is too large for this, it's an impossibility to even remotely immobilize this biomechanically so vulnerable area. And of course, again, this can probably just serve a temporizing function because it really actually does not immobilize this area. So surgical treatment. So these are obviously problems, and I want to really focus on two things before I talk about the obvious, which is posterior fixation. So anterior treatment. I trained initially as a general surgeon, and all of us kind of have this weird penchant in ourselves that we want to do heroic surgeries and big surgeries. I'm going to tell you, at the end of the day, anterior exposures to the cervical thoracic junction, while doable, are extremely maiming to patients. There is no way that you can do a sternal split or a disarticulation of the clavicle that these patients don't have long-standing issues with this. And you can do a brilliant anterior column access, avoid all the major vessels that are floating around down there. This is not a properly accessible spot without leaving a patient with significant long-term damage. So my pitch there is, do think about, and I always like to do my hand motion there, pros and cons, but do you think that, that there's not maybe a possibility to do something different from the back, which is going to be my main point? Sternal splits and costovertebral anterior access surgeries with a flap, which we see in our oncology world quite a lot. You got to have a really good reason to do this because the patients will never be the same afterwards. And it's a maiming thing. And again, always think about my teaching point here, manubrial entry angle. So who's ever exposed T2 from a thoracotomy? Anybody in the room seen that? There's some heroes. Was that an easy surgery, Patrick? On it?
No.
Yeah.
No.
Don't do it. Same thing. And same thing again, those patients will never have a normal scapular function. You basically have to elevate the scapula, fourth rib access point, and they'll have a withered away shoulder. However elegant you are in elevating that, this is simply not, and I've done these, this is not a very conducive surgery. So it's a fourth rib access, and maybe you want to play with that in a cadaver, it's not good. So however you want to do this, the anterior approach is problematic, but then think about the following thing. The very dense rib structure will actually make the vertebral bodies of T1 through T3 very hypodense. So these are not your normal vertebral bodies. You can have perfectly good bone densities at C7 or C6, even jumping down to T1. That's not going to be a very good vertebra. So a standalone construct for stability's sake can be a problem, and these are actual cases that I got to revise. Or this one here, this is actually even C6-7. This is just a bigger mechanical load than this vertebra with that particular screw construct could hold. So there are substantial forces available and subject to this area that are a problem. So for me, the cervical thoracic junction is something that's a posterior problem. It's a tension band access point, and we'll show some ways to get the anterior column reconstruct also. And historically, again, Patrick and I are the same era. We were taught with cables, hooks, and everything like that, and we really struggled to kind of stabilize that area. And again, back in 1990, when I did my fellowship, I had Dr. Anderson, and we really tried to create, these are actually all cases I did. We really struggled to kind of put things together, and every single screw we put in here was a miracle of discovery, and certainly we did not have any navigation. Maybe it was better because we learned how to put in complex screws, but we had to have every piece in the armamentarium available to ourselves to kind of make these things happen and use everything that we had and be as safe as possible. So we've published on this, and again, all of you nowadays don't even think about it anymore, and I'm so glad that medicine has advanced so well beyond what we did. But all of you should have a basic knowledge of how to localize and do that in the lab later. The thoracic pedicles, I take the TPs off completely because this is a very good access point. It's bone graft, it's a posterolateral fusion site, and you will not slip your screw heads off and bounce off laterally or over deviate medially. So for me, taking off the TPs, and I've learned this from Dr. Abumi from Japan, who did a masterful way of making these very safe, but you have to know the basic anatomy. Our fellows do a great job. They actually print out x-rays and hang them up. So this is our little computer system, and we look live on the axial images, have our representatives who are fantastic and who are all taught in this, kind of go level by level, so have an immediate visual reference in addition to a written surgical plan which we hang up. They don't take long to do, and this is our low-tech approach because we don't have the nice nav and the cool implications of working nav to that end, and it's not effective in our end. So integrated dynamic fixation systems, dynamically amenable fixation systems, what I'm trying to say, were a big breakthrough. Now, let's just assume we all have cool hardware systems, but for me, the posterior access has a very major problem. I just was at one of the industry exhibits, and please go network with our industry representatives who make this course possible. The real problem of the posterior CT junction is soft tissues. And why does this happen, and this is bound to happen? I had a big epiphany when I came here in 2014, and it came from a plastic surgeon. We do a bad job reconstructing the soft tissues. You saw all those muscles before? The true cervical thoracic junction should be identified as you access these patients. Ideally, you tag them, especially in larger patients. You want to pull the fat off the fascia, and you want to close the fascia. Literally all of those patients, I can tell you, and these are my patients, had not had a proper closure. The other thing that I've learned is the suture material doesn't matter. I'm going to make a product advertisement here. I'm still sorry about this, but slow resorbing sutures like PDS is way superior to Vicryl. I used to obsess about what I call trapezius diastasis, which is an overlooked soft tissue problem. Trapezius wing, the delta sign. You can see that. You did a beautiful job. The deltoid wings out when the patients come to clinic. You know that if you look at them posteriorly, the spinous processes and the hardware are probably going to be prominent. The fascia has to be identified and has to be closed, and figure of 8, I call them looped PDS sutures. We tag them, especially in larger patients. So don't just sew 2 stitches in, because guess what? The first 2 stitches are going to close everything down. You'll not have a proper fascial closure. 8-10 snaps, especially at the lower end. So you have the anchor point, which I didn't put in as a slide here to my regret. The nuchal ligament is the lower aponeurosis of a cervical spine. So the C5 to 7 aponeurosis is the nuchal ligament. You want to tag that, you want to attach it, and then rostral and caudal that you want to have quality, slow resorbing sutures. Take great pride in that because guess what? Nothing's cooler than having a nice, smooth neck in the back. And I did not know this until 2014. I had diastasis despite multi-layered closures with Vicryl. It just pops off too easily. So these are all the various problems that we can see. Post-operative failures because of poor understanding of mechanics and rehabilitation, trauma, tumors, infections. And this is, again, the big question. And again, just running through some cases, an example, post-traumatic late deformities. Every patient is different. There's some nuances. But basically, this is something where I would always think about, can I somehow do an anterior release so I get this long-standing chronic kyphosis out and then a posterior tension band? And this is what we did. We did an anterior release. We got actually a plate on. I usually don't do a plate anymore nowadays. And then we did a posterior compressive segmental fixation. Problem solved. Infection. This was actually almost a national case, and I recently saw, I should have put a new x-rays in. This was a very cool physician, and she came in from an outside city, and everybody wanted to do an upper thoracic approach to her. This is tuberculosis. She got this while she was in India. And she was myelopathic but had an intact motor score. This is a T1, T2 lesion. And again, everybody said we need to do something. This is an absolutely beautiful human being, very sophisticated, and she just said there must be somebody who does this from the back. Well, you can actually do nerve root sparing surgery. We did a T2 nerve ligation after talking about that, but T1 was preserved. We put cages in, we fixed her, and I recently saw her because she came back to Seattle now, 10 years later, and she's very grateful. And she basically led a normal life after that. We did not have to go in the front. We basically did a costotransversectomy with a single root ligation, saved the other side, did a full debridement and a reconstruction. It is amazing how easy, if you know the concepts of a quality costotransversectomy, how you can reconstruct the anterior column in a very controlled fashion. Degenerative problems, again, very common. There's been a fusion done here or there, the patient kyphosis below, and hyperlordosis at the top. That's a very classic pattern. One of our fellows actually has a paper out now. It's called Bazem's sign, Baz Ishak. He identified this telltale sign of the atlas impinging on C2. That's a compensatory upper cervical lordosing effort to compensate for a lower cervical kyphosis. Classic pattern. This is a hyperfunctional guy, jazz drummer, philanthropist, man of the world, travels the world, lower cervical kyphosis, upper cervical hyperlordosis. He did not want a fusion. We did a selective laminoplasty on the top, and we did a corrective osteotomy below. And this is him showing his outcome scores, and he gave me permission to do this. He actually wrote a song about me. I'm too bashful to play it, but anybody wants to see it, I'm putting it on my laptop. But this guy was very happy with this. This is a very common theme, and again, we have some great SSF TV interesting case discussions, these cervical thoracic failures below fusions. It's usually an under-recognition of inflammatory diseases or a poor muscle tone on the part of patients. And again, if in doubt, and poorly predispositioned patients like inflammatory disease patients cross the cervical thoracic junction, probably T2 is the best. But this is, again, a complex problem, and we basically did an anterior revision and dynamic fixation and posterior rigid fixation. You can argue how low to go. We stopped, I think, at T3 or 4 here, and we went up to C2 in this particular patient, and she actually did quite well. Something that is not an anachronism, and we have a patient like that on the floor right now because he had an infection after my repair surgery, but post-laminectomy, swan necks. This was a routine procedure for me. It's become very rare, fortunately, now. We actually operated on this patient, and this was a bear. This is a 10-hour surgery. I did this actually, Richard, with Tony Avellino. We did this together, and we tag-teamed this. And this was actually led to a very nice extension of this patient's life for many years, with an emphasis on soft tissue structures. Again, the kyphosis below long fixations is a real bear because we have to go much lower. And again, we probably have to cross the thoracic apex of the kyphosis. So we usually have to go down to about T12 or L1, such as done in this patient. But the point is, you can do very nice deformity corrections at the cervical thoracic junctions to something that we have popularized now, thanks to Dr. Oskuian, which is the intradiscal osteotomies. So fixing these from the back is totally possible without any nerve root sacrifices. Conclusions, CT junction, an unresolved issue without a question, a substantial problem, very disabling. This patient had significant problems with dysphagia, dysphagia. These are different entities, freak misnomer. And she basically had aspiration pneumonias. We had to put a feeding tube into her and we straightened out. I don't know whether to show her images, but she's one of those very, very happy patients. Next time I'm going to show those. So for me, the biomechanics part from posterior approaches has been resolved, and yes, we can do an anterior column reconstruction very effectively. The prevention is something where we have to be far better engaged, early recognition, pattern recognition in this regard, and interception, working as rehab doctors de facto, not trusting PTs, being actively engaged in this. I still, when I have a patient who comes with the dowager's hump, lay them on their table, I do the recumbent test, and I see how much their C-spine relaxes and whether they can get their occiput effortlessly without a pillow onto the table. Anterior approaches below T1 in general, using that term as a very important distinction, are not desirable unless there's a very specific circumstance. And you can do a very nice reconstruction, resection, whatever you need to do through costotransectomies transectomies without sacrificing the T1 root. And the posterior systems that you can see later in the lab are really cool. They've been a breakthrough, but repair the soft tissues. That's what I got to say. Thank you. Unless there's an urgent question, may I ask that we proceed? Dr. Sanser, are you logged in here or on the?
I think I have.
Good. And this is your pointer. So any one single question? Patrick, put you on the spot.
Great talk. You know,
Anything that I omitted?
don't be afraid to split the sternum in people if you have to.
When do you have to? Elaborate.
Well, if you have a ventral cord compression that is not going to be resolved with a posterior operation, or you can't do a posterior osteotomy, transpedicular. I saw you used one of my illustrations up there. Thank you. That's okay. That's okay. The transsternal operation. I mean, I've done about a dozen of them in my entire career, which isn't many, but on the other hand, there are places it needs to be done, and just don't hesitate to do it because it's really simple for the cardiac surgeon to come in, split it. They'll usually do a L-shape incision and not split the entire sternum, and you can get down to about T4 and treat it like an ACD kind of procedure, whatever reconstruction you do after you do a vertebrectomy or reconstruction.
The stability is actually inferred from the posterior side, so would you agree? So this is a pure anterior.
No, you don't. It's not a standalone. Never. Those are front back. Anything junctional, I think, in the whole spinal column is almost always a front back.
Thank you. Our co-chair and visionary creator of this whole conference, Dr. Charlie Sanser, Vice.